Good morning, respected faculty members and dear residents. Today I am going to present a case of 51-year-old para to living to resident of Punjab, homemaker by occupation, diagnosed case of carcinoma cervix stage 2B post EBR, post external beam radiotherapy, referred to gynecologic oncology from radiation oncology. Initially, she had presented in September 2022 with chief complaints of postmenopausal bleeding for past 6 months. There was no prior history of postcoital bleed or no history of prior screening for cervical cancer. And she attained menopause 10 years back. Previous cycles were regular, average flow, smooth perimenopausal transition. She is a para to living to, married for 35 years lady. Last childbirth was 32 years back and had underwent mini lap ligation 30 years back. Her past and family history was not significant. Pre-radiotherapy, her examination findings were pervaginal uterus was irregularly enlarged, 10 to 12 weeks period of gestation. On perspeculum and pervaginal rectal examination, 4 into 4 centimeter cervical growth was felt involving upper 1/3 of vagina. Bilateral parametrium was free, rectal mucosa was free, and the clinical impression of stage 2A carcinoma cervix was made. Cervical biopsy was taken in the same sitting in OPD. Now, the biopsy findings will be discussed by Dr. I request Dr. Akansha to explain the biopsy findings.
Good morning, gentlemen. We received one biopsy on 29/8/22. Received three grey white soft tissue pieces, altogether measuring 2 into 1 into 0.8 centimeter, which was all embedded as A1. On microscopy, on scanner view, we can see the cellular infiltrating tumor arranged diffusely in sheet. On higher power, these are the tumor cells showing high pleomorphism and mitosis, which is having high NC ratio, vesicular chromatin, and eosinophilic cytoplasm, labeled as yellow arrow. And these red cells are the inflammatory infiltrates. On histomorphological features, we diagnosed it as a non-keratinizing squamous cell carcinoma.
Thank you, Dr. Akansha. I now request Dr. Pooja from Department of Radiology to please explain the pre-radiotherapy imaging findings.
Good morning, respected teachers. This is CMRI pelvis that is performed before the radiation therapy. Here we can see uterus appears lobulated in outlines with multiple T2 hypointense intramural fibroids causing distortion of the endometrial cavity. Here is the endometrial cavity. Also, we can see a well-defined T2 hyperintense lesion arising from the posterior lip of the cervix. Inferiorly, it is involving the upper 1/3 of the vagina, and superiorly, it is involving the lower segment of uterus. On axial section, we can see a T2 hyperintense lesion arising from the posterior lip of the cervix. At some places, here we can see a well-defined hypointense rim around the lesion. However, on right side, there is loss of the hypointense rim that's suggestive of parametrial invasion. Posteriorly, it is abutting the rectum. However, no infiltration of rectum is seen. Anteriorly, no infiltration into the urinary bladder is seen. No significant pelvic lymph nodes are seen. On diffusion weighted images, we can see the lesion is showing diffusion restriction. On post contrast images, We can see the lesion is showing heterogeneous enhancement. However, no significant lymphadenopathy is seen. Coming to sections of upper abdomen. No enhancing lesion is seen in cervix. No enhancing lesion is seen in liver, so there is no liver metastasis. No hydronephrosis is seen in bilateral kidneys. No significant retroperitoneal lymph nodes are seen. So we have T2 hyperintense lesion showing heterogeneous involvement and involving the parametrium on right side. However, bilateral ureters, rectum and urinary bladder are not involved. So radiological stage is 2B since parametrium is involved. Thank you.
Thank you, Dr. Pooja. Coming back to the case history, following this diagnosis, patient was sent to the radiation oncology department where she received 25 fractions of 50 grays of EBRT in total 25 fractions with concurrent chemotherapy carboplatin as she had a sensory neural hearing loss and that too AUC 2 was given weekly for 5 weeks. On imaging, prior to brachytherapy, she was found to have multiple intramural and subserosal fibroids, largest 4 into 4 centimeter, and more than 50% were intramural, distorting the uterine cavity and occluding the lumen. So, brachytherapy was not feasible, and hence the patient was referred for surgical management. On examination post EBRT on 17th of December 2022, patient was ECOG PS1 vital stable. There was no axillary, inguinal or supraclavicular lymphadenopathy. On per abdomen, per abdomen was soft. There was no mass palpable. Post-radiation skin changes were seen. On per-speculum examination, anterior lip was seen. However, posterior lip was flushed with the vagina. There was no obvious growth. Vagina was normal. On per-vaginal examination, uterus was enlarged, 10 to 12 weeks period of gestation. Irregularly enlarged, cervix was firm, flushed. Bilateral fornices were shortened. On per-vaginal rectal examination, rectal mucosa was free, left parametrium was free, however, right parametrium mild thickening was present. So, a clinical impression was made. 51-year-old para to living to, known case of carcinoma cervix stage 2B, post 50 gray of EBRT in 25 fractions with multiple fibroid uterus for surgical management. Her pre-op evaluation was done in which since she had a left ovarian cyst, which is simple, the tumor workus we got it done, which was within normal limit. CE MRI pelvis was again done post EBRT to look for the feasibility of surgery. PET CT was done to evaluate for the residual disease in the pelvis as well as distant metastasis, if any. And CT urogram was done to delineate the ureter course so as to rule out any functional or structural obstruction of the ureter. Now I would request Dr. Pooja to again come and explain the post EBRT imaging findings.
The CMRI pelvis post brachytherapy. In this also we can see multiple intramural and subserosal fibroids in uterus distorting the uterine cavity. However, no hyperintense lesion is seen in the cervical cervix. On diffusion restriction, no diffusion restriction is seen in the cervical canal. This is the cervical canal. Here we can't see any hyperintense area, so no diffusion restriction is seen. On post-contrast images also, no enhancing lesion is seen in the cervical canal. No significant lymphadenopathy is seen. So post EBRT on CMRI pelvis, no residual lesion is seen. Thank you.
CT urography for this patient was also done, which showed no significant hydroureteronephrosis. The ureter course was normal. Whole body PET CT showed FDG avid left external iliac lymph node, 1.3 into 0.8 centimeter. SUV max was 4.4 centimeter. Mild ill-defined standing in the pelvis. Query post RT changes. Non-FDG avid cystic lesion in left adnexa. No residual lesion in cervix, and there was no metastasis anywhere else in the body. So plan was made, and the patient was, after adequate preoperative workup, patient was taken up for exploratory laparotomy plus type B radical hysterectomy plus bilateral salpingoophorectomy and pelvic lymph node sampling on 25th of January 2023. Intraoperatively, uterus was enlarged with multiple subserosal fibroids, largest 5 into 5 centimeter on right side of the anterior wall of uterus. Right tube and ovary was healthy, left tube was healthy. Left ovary 4 into 4 centimeter clear cyst was seen. Uterus with cervix with 2 centimeter of cuff of vagina with bilateral tubes and ovaries were removed. One enlarged left external iliac lymph node was removed, around 1.5 into 1 centimeter. On cut section, multiple, as we can see, this is uterus is enlarged with multiple subserosal and intramural fibroids. One fibroid specially obliterating the endometrial cavity. The endocervical canal was normal, and there was no lesion seen on the cervix. Patient had an uneventful post-operative course. Perioperatively, operative ERAS protocol was followed. Catheter was removed on post-operative day 7, and patient was discharged in stable state. Now I would request Dr. Akansha to discuss the final histopathology report of the patient.
So this is the requisition form we received. We received 2 containers. Container 1 labeled as total hysterectomy with bilateral salpingo-oophorectomy. Container 2 was labeled as external iliac lymph node. This is the gross picture. So we receive in gross there is no tumor seen in the cervix, and however myometrium shows multiple fibroids ranging from 1 to 5 centimeter in diameter. So from the serial sectioning, this is the squamous epithelium is showing no evidence of dysplasia, and subepithelium shows the chronic inflammatory infiltrates. Thus, this is the chronic cervicitis.
Use the cursor.
Mouse use karo, mouse.
Okay. So, squamous epithelium shows no evidence of dysplasia, and subepithelium shows chronic inflammatory infiltrates. So, this is the chronic cervicitis. Here we can see this focally eroded epithelium. This is the atrophic endomyometrium. So, this is on the low scanner view. We can see there is the leiomyoma, and on the higher power, there is the spindle cells arranged in the fascicles and walls. No EDPR, no necrosis or mitosis is seen. So this is the leiomyoma. This is the sections from the ovary. So here we can see the corpus albicans and the age-related changes. And this is the bilateral fallopian tube sections. This is unremarkable. This section is from the external lymph nodes. Iliac lymph nodes showing the calcifications. So in cervix there is no evidence of residual tumor. In endometrium there is atrophic endometrium. Myometrium shows multiple leiomyoma. Bilateral fallopian tube and ovaries are unremarkable. External iliac lymph node shows 3 lymph nodes with calcifications. So there is some data. We divided L cell and S cell.
What was the histopathology of lymph node?
Normal.
So it is normal with showing calcification. So these points on the radar.
PET-CT image नहीं है.
Report.
See PET-CT image.
No.
Okay, well, LC is divided into SIN1, cervical intraepithelial neoplasm 1, which shows the mild squamous dysplasia, cholestatic atypia, and cholecytosis. Lower third of the epithelium shows proliferation of basal or parabasal-like cells, while SL is divided into two entities, SIN2 and SIN3. SIN2 shows moderate squamous dysplasia, full thickness nuclear abnormalities with accumulation of cytoplasm in the uppermost cell layer, while SIN3 shows severe squamous dysplasia, squamous cell carcinoma in situ with full thickness basal and parabasal atypia without appreciable difference in uppermost and lowermost epithelial lesion. So this is the low-grade squamous intraepithelial lesions, and this is high-grade squamous intraepithelial lesions.
Why are you discussing this here?
Ma'am, this is some literature for this.
But this is a carcinoma cervix case, right?
Yes,
so
ma'am.
why are you discussing this here now?
Ma'am,
This is pre-invasive
yes,
cancer.
ma'am.
And I didn't understand the context.
Actually, that is not relevant here because already it's
She's
diagnosed
just trying to
cancer.
discuss all the lesions of the squamous epithelium.
Right now, these were the lesions seen.
Like, ma'am.
After radiotherapy, you had...
No, ma'am. This was after radiotherapy, the uterus was free.
Nothing seen.
Nothing.
So this was not relevant here, right? Because this is a case...
We can escape.
Yeah. You understand? This is not relevant for this case.
Squamous cell carcinoma can be associated with HPV associated or HPV independent. HPV associated squamous cell carcinoma are more common in 6 decades of life. It is the fourth most frequent cancer in women. High level expression of viral oncogenes E6 and E7 is associated. P16 shows strong block positivity in HPV associated cervical squamous cell carcinoma. HPV type histological pattern do not have any prognostic implications. HPV independent squamous cell carcinoma most commonly occur in 7 decades. About 5 to 7% squamous cell carcinoma are negative for HPV. It has higher risk of abnormality, P53 immunostaining, and also associated with KRAS, ARIG1A, and PTEN mutation. Mostly diagnosed on advanced stage, and they have higher rate of lymph node metastasis, conferring reduced disease-free and overall survival. Thank you.
Thank you, Dr. Kancha. Now we'll be proceeding to the discussion part pertaining to this case. So first of all, why not radiotherapy? Why the modality surgery was chosen for this patient? So coming to radiotherapy issues in a case of cervical cancer with uterine fibroid, there are concerns. The two questions which arise are concerns while giving radiation as primary modality and the dose or technique of radiotherapy in cervical case with uterine space occupying lesion, if any modification needed. This is the literature showing how what are the difficulties of applicator placement in cases complicated with fibroid. So before applicator placement in brachytherapy, it requires a review of the pre-implantation imaging and clinical examination. Special attention is paid to the distance from the cervix to the fundus, and if cervix cannot be sounded because of the radiation changes, slow serial dilatation can be attempted. Another modality nowadays is stereotactic radiotherapy, which is an attractive alternative to brachytherapy in small pelvic tumors. It is highly conformal radiation dose delivery with minimal side effects, and it can be of potential use in benign uterine lesions like leiomyoma, although the dose and use is not standardized yet. This is a case report in which by Chen Hee Hien, in which a 46-year-old lady with stage 3B cervical cancer with fibroid uterus underwent EBRT, concurrent chemoradiation therapy. In this also, they encountered multiple uterine myomas with bleeding tendency, and they used helical tomotherapy, guided stereotactic radiotherapy, 24 grays in 6 fraction over 1 week in place of brachytherapy. And they revealed, and their outcome was good, and they revealed histopath revealed no residual. However, TH was done ultimately for acute AUD, and histopath revealed no residual tumor. So, coming to issues in surgical management after EBRT, we'll be discussing further workup which is required after EBRT and prior to surgery in this case. When to operate after EBRT, what is the technique and radicality of surgery in a woman post radiation, and what are the anticipated complications. So coming to preoperative workup, first of all, we'll go ahead with assessment of the pelvic operability. So in clinical examination, if there is history of unilateral leg pain or edema, it is suggestive of inoperability. Then assessment of parametrium is done. If involved, it is suggestive of fixity to pelvic side wall, which obviates the tumor-free margin and hence the local resectability. If the clinical examination is suggestive that we can go ahead with surgery, imaging is done in which ultrasound kidneys, bilateral kidneys is done to exclude the hydroureteral nephrosis. Then distant metastatic workup is done and local pelvic resectability is confirmed. For this, PET-CT has been shown to have a higher sensitivity than CT or MRI for distant metastasis. However, no significant difference for local disease detection is seen. Then after the metastasis has been ruled out, we assess for pelvic operability. For this, we now take the decision whether we are to offer exentration or conservative surgery to the patient. For this, MRI and or CT both are good enough to look for parametrium involvement and cervix bladder or cervix rectal plane involvement. MRI at present is the imaging modality of choice for parametrium involvement, bladder plane and pelvic sidewall involvement, which we did in this case also. So now, how is surgery different in this case in a post-irradiated cervix? First, the preoperative workup has to be done, which I have explained. Then, contraindications to the surgery will include intraperitoneal metastasis, unresectable pelvic sidewall, parametrial involvement, and unresectable nodal involvement. In this surgery, specific attention is paid to the mesoureter, which is preserved throughout its lateral aspect, and ureter is not detached from the peritoneum till it enters the McEnroe ligament. And also an extension of trigone musculature extends as a fibromuscular sheath and covers the lower ureter for 2 to 3 centimeters. Dissecting in this plane outside this fascia is very important in this case to prevent skeletonization and postoperative fistulas. Then monopolar cautery is avoided near ureter, and bladder is to be dissected sharply, not bluntly. Dissection with ureteric stents predisposes the ureteric stents predisposes the ureter to injury. So in this case, if stenting is deemed necessary, insertion is done at the end of the dissection. No deliberate attempt is made to remove the facial sheath from iliac vessels. Hypogastric artery is not to be ligated in this case. Bilateral hypogastric artery ligation can result in significant bladder ischemia in post-radiotherapy patients. Also, a complete lymphadenectomy is avoided in this case to prevent the morbidity of lower limb lymphedema. So, salvage, now coming to timing, salvage surgery for residual disease post radiotherapy is done after a few weeks. The time interval, there is no definite time interval recommended, but it can vary from 6 to 8 weeks post radiotherapy to 14 to 8 weeks in reported literature. Also, biopsy for the residual disease is important prior to salvage surgery, because 70 to 100% of cases has been shown to have a post-positive biopsy showing residual disease on final histopath. This is a original article published in 2020 by G. Young, in which he compared the outcomes, progression-free survival and overall survival in patients undergoing completion hysterectomy after chemoradiotherapy versus chemoradiotherapy alone. So he found that the overall survival and progression-free survival was better in the patients undergoing complete hysterectomy after chemoradiotherapy, especially in the group age less than 60 years, stage 2 disease, and size more than 4 centimeter, cervical stromal invasion, parametrial involvement, and lymphadenopathy. Coming to interval between RT and surgery, this was explored in Indian study by Kundrangi et al. In 2013. In this case, 38 patients with no parametrial involvement and no distant metastasis on imaging underwent type 1 radical hysterectomy with pelvic lymphadenectomy within 2 months of completion of EBRT. He found that wound infection was the most common complication in his series, which were accounting 13%, and 65.8% patients were recurrence free at 5 years, and mostly were stage 1B and 2A. Para-aortic lymph node was found to be the most common site of recurrence. Then what are the anticipated post-operative complications in such a case? Bladder atony is the most common one, which can be we can avoid this complication by either clean intermittent catheterization or continuous bladder drainage for 2 to 3 weeks. Then urinary fistulas, lymphocele, hydronephrosis, intestinal obstruction, and lymphedema of lower limbs. Post-operative management, the question arises, is there any need of further adjuvant treatment? Since the patient, since this case, there was in the final histopath no residual disease was found, the decision of only observation follow-up was made. Then what about the follow-up? We are following the NCCN guidelines for this patient, which is interval history and physical examination. Patient is being called every 3 to 6 monthly for 2 years, and then followed by 6 to 12 monthly for 3 to 5 years. And if there is any clinical suspicion, then imaging will be ordered. Last visit in her OPD, we ordered a PET CT scan which showed no metastasis or residual disease.